but that particular slide doesn't.
Okay.
Thank you.
So I really just wanted to clarify whether it was you're describing it as a trend or whether you were summarizing what the author said. So I appreciate the clarification. Can I ask one more?
Of course.
Okay. So
Actually, and we'll just, as a process, put up your tent card if you want to ask a question. You don't have to do that anymore. Thank you. You can put it down now.
all right. So another question, and I think, again, this information was presented in multiple presentations, but the MedPAR data that looked at mortality reductions over time with TAVR, I'm wondering if one or more of the speakers wants to discuss how that information potentially could be confounded with temporal trends in length of stay, which also seems to be the case over time. And in addition, unless I'm mistaken, MedPAR collects data not only on in-hospital mortality, but also 30-day mortality. And again, I didn't see 30-day mortality highlighted as much as it probably should be in this kind of a circumstance. So whoever would like to talk about that.
Thank you, Marty Leon. Yes, we did present the in-hospital data, which was the only data set that we had available to demonstrate those trends. I think your question is an interesting one, suggesting that if there's reduced length of stay, that the in-hospital mortality would be less simply associated with reduced length of stay. I don't believe that that is the case. I think that those are true differences in mortality that have been confirmed in innumerable other data sets, including the TVT database and including a variety of other randomized and other clinical trials that have been developed over time. I think one of the important differences is that over time that the risk strata of the patients change. And in the beginning we treated the sickest patients who were higher risk, and progressively over time, that scaled down to higher than intermediate risk patients. And I think that probably is more of a confounder in explaining the reduction in TAVR mortality than anything else.
Yeah, and I probably should have been more clear. I was kind of linking the two ideas because I'm not trying to claim that length of stay is an explanatory factor in mortality reduction, more that it's a case-finding issue. And so that's why I would think that the 30-day mortality would be a more precise measure.
Yeah, I think that there's a couple of comments. I mean, that slide of the SAVR, TAVR, MedPAR 5 or 6 year data was shown at least 3 or 4 times, I thought. So from just a couple points different from what Marty just said. Number one, the MedPAR data for the SAVR part is about it's a claims adjusted thing, and it's not precise about AVR only. So this is any, in the MedPAR data, any person who gets an aortic valve of any type, whether it's a double valve, whether it's an AVR cabbage, whether it's whatever, is in that database. Because the STS isolated AVR database for patients over the age of 65 is 2.06% for 2017. The second thing is really more important, exactly what you're talking about, which is why the TVT registry is going completely away from in-hospital metrics to 30-day metrics. One of the, you were exactly right, it has to do with length of stay. The length of stay is going down, so the delta between the in-hospital mortality rate and the 30-day mortality rate is actually going up. And what's happened is that for any of the procedures that we see in cardiovascular surgery or medicine, the delta between in-hospital mortality rate and 30-day mortality rate is actually the highest in TAVR. It's pretty unnerving, actually. So the in-hospital mortality rate is basically worthless. And the 30-day mortality rate is really, really important. And so I agree with your point.
Thank you.
Actually, Eric Vang. So if I can just maybe address the question around the 30-day mortality. So using MedPAR, this is, again, was on the handout that I actually had, and I think everyone's got that. But if you look at both the slides on both graphs, both the graphic volume looking at the adjusted and unadjusted weighted averages, and we actually focused on 30-day mortality. So that actually does include that for the specific volume and for specifically TAVR.
Please. I can't actually see. from the end, maybe? I wasn't watching the sequence. Go ahead,
So, can I start?
please.
Thank you. Patrice Mickens. You know, we've had such focus on volume, you know, for obvious reasons, and I was wondering, we have training, you know, people that have recently trained or training directors in the room, and I was
I'm sorry, can you speak into the microphone?
I'm sorry, can you hear me now?
You have to be quite close for this.
Yes, so I was, I wanted to ask about, in training for procedures, Tavir, is it a number that you look for? What are the qualifications that you look for as you are training someone to use this procedure? And then what do you follow? You know, and how many do people do in training programs to say that they're then competent to do this unassisted?
Carl Tomaso. Very good question. The criteria we put in the manuscript was that people had to participate in 100 transfemoral TAVRs and be first operator in 50 transfemoral TAVRs. The point of the difference between the 2012 and the 2018 document is we did away with prerequisites. If you're going to do TAVR, you have to be trained to do TAVR. And I don't know that any of us know the numbers that specifically you're asking, but there are probably 20 to 30 trainees finishing every year, both interventional cardiologists and cardiac surgeons, plus a number of people who have been junior operators and undergoing a preceptorship who meet these numbers. There's an adequate number of people, if that's the question you're getting at.
Yeah, so I guess my point more was towards this, you know, the focus on number, if you will. There are simulations, there's all kinds of ways for people to, you know, develop the skills, if you will, to manipulate catheters, et cetera. And so, you know, the focus on volume seems a little misplaced.
But a lot of it is the evaluation of the patient, the pre-op management, the selection of the valve, not just going into the laboratory and blowing up a balloon with a valve on it in the aortic annulus. It's also the post-op management. It's knowing when you have to call EP. It's knowing when you have a bleeding problem. It's more than what you can do with just simulation. We have simulation in our institution for PCI for a number of procedures. It doesn't replace the actual patient care.
Thank you.
Tor-san, if I could, I think I'm following where you're going with this. If the question relates to the use of volume criteria as a surrogate for competence, for example, I'm on the American Board of Thoracic Surgery, and my board, like everyone else's board, I would imagine, certainly proceduralist boards, to get board certification, we all still incorporate case volumes, case numbers. Is that a perfect way to assess competence? No, but yes, it is still a common part of the way we as professional organizations address that issue, imperfect as it may be.
I just wanted to speak to kind of the real world issues of training centers and physicians for doing TAVR, which I think is a little bit about what you're trying to get to, because at Columbia we do training courses every other week, and we've trained 55% of the centers in the United States to become qualified for TAVR. It's generally a 1.5-day course. The centers are identified based upon the ability to demonstrate that they have a functional heart team, that they have competent individuals who can do surgery, who can do cardiac imaging, who can do interventional cardiology with endovascular experience and PCI experience as well. Once a site is identified, they go through a fairly intense training program. There's an online portion, there's an in-person portion. We have to validate that they're able to correctly do the pre-procedure planning that was just discussed. Then there is a proctoring period of as many cases as is necessary to be able to demonstrate that the site has operators and a functional team that can orchestrate doing the procedure correctly. So it is a very intense and rigorous process, more intense than any other interventional procedure that's ever been devised in interventional cardiology. And I think probably as intense as a training program that you would see with surgical procedures. There's also refresher courses as new techniques become available, so there's an ongoing process to train these centers, which I think has helped to result in some of the outcomes that we've observed. I would never argue that there shouldn't be some case volume threshold. The question is, to me, that if it ain't broke, don't fix it. Right now, the NCD has certain volume thresholds. Whether that needs to be adjusted slightly in one direction, I would not take issue with. You clearly have to have a functional environment with experienced people who can demonstrate excellent results, and there has to be transparency and there has to be oversight to make sure that the lower volume centers are not straying from the standpoint of what would be appropriate clinical outcomes, with a shift from volume to outcome metrics so that sites know how well they're doing and can improve and aspire to get to within what we think are the most credible thresholds of excellence.
Thank you.
Just to follow up on that, clearly I believe that there is a volume-quality relationship when you're training and learning. I don't know what the number is, but there probably really is that relationship. And I hope that the committee will separate that, because when you train, you need to learn how to do this and be competent at all aspects of it, as Dr. Tommaso said. But that has really no relationship between how many PCIs a whole hospital does or how many surgeries a whole hospital does.
Thank you. Mark? Oh, I'm sorry.
Ted Feldman from SCAI. Another really critical part of the volume discussion, both in training and in practice, is the management of emergencies. And in a very paradoxical way, as TAVR has become safer, for a trainee, the frequency of emergencies to learn how to manage real time and to have experience with has become less. And that does drive the need for volume. And I would argue that after training, it's no different in real practice, that you have to have the aggregate of experience with PCI, TAVR, and surgery to be facile as a team to manage emergencies. And those are low-frequency events, so that takes a lot of experience.
Thank you. Okay, Mark, please.
Thanks, Peter. I think my question is for Drs. Leon and perhaps Bavaria. If I understood correctly, different eyes have looked at the same data set and come to very different conclusions about relationships between volume and outcomes. And there was mention of the term weighted analysis versus unweighted. Could you speak a little more to what that is and why one approach is better or more appropriate than the other?
We have looked at the data as exhaustively as we can. The TVT registry really comprises data from two specific valve types. Those data are available to the companies that functionally own those data, and we've looked at those data sets and have attempted to replicate as carefully as we can the analyses that were done by the consensus document, and have been unable to replicate the observation that there is the kind of volume outcome relationship that would suggest, importantly, that we increase TAVR volume requirements. The only way that we can get close to replicating it is if we looked at volume groups, and instead of doing a weighted analysis, that an unweighted analysis was done. So quite simply, an unweighted analysis would be taking every center, looking at their annual mortality, and simply averaging those annual mortalities, as opposed to a weighted analysis where you look at, for that particular grouping, that group of, let's say, 0 to 50 cases, you looked at all of the deaths and all of the cases, and then created a number which represents the totality of that grouping. So the only way that we could replicate or get close to replicating the data that was shown was if an analysis that was unweighted was performed, which from a methodologic standpoint we felt was the less robust way to do those kinds of analyses.
Actually, it's a technical, it seems to me that using a random effect is the right way to do this analysis. So is that what was done? Which is different from a weighted analysis. Okay, I'm sorry.
We don't have our representatives from DCRI here today, but I can assure you it was not based on aggregate data as was just described. That's pure supposition. We would never do an analysis like that when looking at volume and outcome at individual centers. So I can tell you that's not what was done.
Thank you.
Yeah, obviously Dr. Sheehan is the statistical expert for the ACC and STS databases. But from the standpoint of the DCRI analysis that we put up, and John Carroll's here, I'm sure he'll say something as well. Both of us are the co-chairs of the TVT registry, so that's so we're intimately familiar with this. One of the big differences everybody should know is that data is the data from all transcatheter valves, not just Medtronic or Edwards or any of the. It's the entire data set, and it was presented in a couple of different formats regarding raw data, ODE ratios based on TVT, and ODE ratios based on STS. So it was presented in a number of different ways. I cannot comment on the weighted versus unweighted issue.
I think your question is good, and I don't think you're really able to see the specific methodology based on 5-minute presentations, and that's critical. Secondly, if you do split the total data set into 2 halves, you reduce the power of detecting differences. Number 3, as I tried to illustrate, yes, due to the initial NCD and the volume requirements, et cetera, outcomes have improved, some advances in technology, some learning curves, some lower risk patients, but the outcomes have improved, and so statistically, to look at site performance, you really have to move from just using one metric like mortality to use a composite. And you've looked at some of the data shown where it didn't show mortality difference between different volume bins. You saw this consistent trend with low volume sites. And so you have to look at composite outcomes. And that's what we're doing in the TVT registry. That's really more up-to-date, more robust, and will give us more meaningful insight into performance differences with the goal of not shutting down sites, but allowing sites to have feedback and to improve. That's so critically important. And God forbid if the NCD should not be renewed because we don't have any accreditation process to take over to allow a monitoring of, if we move to purely quality metrics, who's going to do anything? This is just site reported. It's up to the sites to do their internal QA, QI. So we've got to get going in terms of developing an accreditation process using robust metrics that are composite metrics that have a valid risk adjustment. And that's one of the reasons why we have to gather so many data elements in the TVT registry to do valid, scientifically strong risk adjustment. You can't just do that as, is your grandmother alive or dead at 30 days? You've got to understand what goes into these differences in mortality and other major outcomes.
Great, thank you. Eric?
So one, I think I want to address the weighted versus unweighted. As we looked at trying to understand the
Eric,
analysis.
I'm sorry. Sorry to interrupt. So we're all familiar with you, but may I ask each of you state your name and your affiliation? And as I mentioned, you don't have to disclose your conflicts again.
Eric Vang with Medtronic.
Thank you.
So I want to address the weighted versus unweighted, and as we get into the discussion around methodology, I think that's really the key to understanding the evidence. As we've discussed the need for evidence-driven decisions, this is where we're trying to understand as industry how best to understand the data that's in front of us. Replicating the data that we had with the TBTR, yes, it was our own data, hence is also why we actually looked at the MedPAR data, which is comprehensive of all. I don't think we fully understand, and I think the discussion at hand of 5 minutes isn't justice to understand what's being presented. But again, one of the concerns, or at least the ask, is trying to understand the methodology to really derive at the answer. We do know that the complications around this analysis is complex. It's confounded by risk. It's confounded by volume, just a number of different things, including technology. And so I think there is a need for a better understanding of the methodology to really derive at the answer.
Thank you. Sure. Just try and stay focused on the question, but name
Sure.
and affiliation.
Marty Leon, Columbia, AdvaMed representative. Just 2 points. Composite endpoints are difficult. When you look at the TVT registry and look at certain of the composite endpoints like stroke, quality of life, the ascertainment of those endpoints is difficult and has not been fully validated, so it becomes problematic as we begin to move forward. These are things that we have to overcome, certainly, which I think is important. But it would be difficult right now to suggest that we have enough data and composite endpoints to indicate that we can determine quality.
Thank you. So, okay, Dr. Pelican.
Peter Pelican, Santa Monica. I just want to take one issue with one thing that Dr. Carroll said, and that is he attributes the improved quality to the fact that there is an NCD. There's no way to prove that statement since we have not been doing TAVR without an NCD. It has just been in existence. So that logically cannot be concluded. If we look at other procedures where there is not an NCD, let's take coronary stenting, for example, there's been steady improvement over the years without an NCD, without volume criteria. Thank you.
Thank you. Sultan?
Yeah, actually, if you don't mind, just as there's no risk of over-disclosure. I have no TAVR conflicts, but I want to mention that I gave a talk for Grand Rounds on PFO closure that Abbott reimbursed me for. I'd rather have that out there. The other is that CMS, I noticed this morning, gave me a degree, Master's in Public Health, which is nice, but would be surprised to my parents who paid for my education. So I want to follow up on something Dr. Carroll said. Dr. Bavaria showed us the observed versus expected ratio for 30-day mortality, and I'm fond of full disclosure slides so you see every data point. And he pointed out that 96% of those with an OE ratio over 2 were in the low volume group of less than 100 cases. Dr. Pelican showed us the curve reversed to some degree and said that a significant number of the hospitals doing less than 50 cases had no mortality, and he said, well, this was a marker of high quality in those institutions. So my question relates really to how much risk adjustment we have, how good the risk adjustment is, whether the speakers believe the risk adjustment to the extent we have it, and how much can we say about that zero mortality as a marker of, in fact, as a marker of quality, if it is.
Well, as I mentioned in my remarks, Dave Sheehan, STS, as I mentioned in my remarks earlier, we know nothing about a program that does 30, 40, 45 cases and has zero mortality. Chances are they're going to have a substantial number of deaths in the second 50 of their first 100 just by random chance. We can make no inferences about their quality, and that's the crux of the second argument favoring volume thresholds. We simply cannot determine the quality of a program that's doing 40 cases.
But do we know anything about the risk level? In other words, the STS scores of those low volume
Well,
sites.
Dr. Carroll's presentation showed that the issue is not that these sites are doing harder cases. In fact, they're doing cases that are less complex.
Thank you. Actually, can I follow up on that? Not necessarily with you, Dr. Sheehan, but I was struck by that as well. So when you get in the high, I'm allowed to ask questions, by the way. When you get into those high volume categories, in many of the slides, there were 0 facilities that had perfect scores. In fact, they all seem to have some mortality rate. And so I think it was Dr. Pelican, but a number of people focused on these low volume hospitals, zeros. And my question for you is your interpretation of the data that these low volume hospitals' 0 rates are better than these high volume hospitals, none of which have 0 rates?
Peter Pelican, Santa Monica. So When Dr., if I'm pronouncing it correctly, Sheehan says a hospital that does 40 cases and has 0 mortality the next year is going to maybe have 30 deaths. There's no way to really know that either, and that statement is based on a presumption that volume is a predictor of quality. And really there is no data supporting that. There are ways around that. You can look at over multiple years how a program does. There are many different ways to analyze that. So I think simply saying that we throw our hands up and we can't evaluate quality in a world where we now have medical records that are electronic, speaking to the risk adjustment, where hopefully if the people putting the data in the medical records on the problem list or their preoperative testing, it's all there, so we can assess that.
But I mean, maybe it's an unfair question, but I did ask, do you conclude from those data that those 0-event hospitals are better than any of the high-volume hospitals that, because as I pointed out in those graphs as I read them, you don't have any high-volume hospitals with 0 events. And you're relying a great deal on those 0 events as a signal of quality.
Well, actually, I relied on the lower left quadrant there showing low event rate, not 0. There clearly were some with 0, but there are also a number of hospitals, or if you're looking at coronary stent implantation, a number of operators at low volume who have 0 or low or acceptable mortality rates. So I wasn't trying to draw a conclusion that they were better. Clearly that, I don't think you could conclude that. Second of all, I was not in any way saying that these are fabulous hospitals that have 0 mortality, because anytime you do a procedure, there's going to be complications. So I wasn't implying that at all.
Why can't you conclude it? You pointed to those and said they have 0 events.
Well, I'd be happy with that, but I'm not saying they're better or worse. I'm not sure what the error bars are there, and I'm not sure, I'm not enough of a statistician to make that comparison. But on the other hand, I wouldn't throw my hands up and say, okay, you had 0 or low mortality, but we don't know what that means, so we're going to exclude you.
Okay, thank you. Is it on that? Yes, on follow-up? Yep.
So, and again, Dr. Pelican, this is for you. Dr. Bach emphasized your focus on the facilities in the lower left-hand corner, the low-volume, 0 mortality facilities, but in both Mascucci's study and in the 2013 competency document for PCI, what she didn't point out was the studies in the upper corner, that's the upper left-hand corner, which were the low-volume facilities that had high mortality. And that actually came out in the most current version of the Combined Society document, that's really a focus that we have to key in on. And how do you respond to that?
Peter Pelican, well, I completely agree with you, and my entire thesis, not just me, other speakers here, is that we should look at quality. If a low-volume, low-quality institution exists, they should not be doing TAVR. If a high-volume, low-quality institution exists, they should not be doing TAVR. So I'm in no way ignoring them. I'm in no way, should my words be construed to mean that I think all low-volume centers should be doing TAVR. I'm simply saying that we need to make this decision based on the quality of the program, not on the volume.
As a follow-up, I agree, quality trumps quantity every day of the week. I don't think anybody would argue about that. But how can you measure quality with no volume? Now, no center is going to do 0 volume, but as Dr. Shaheen, I think, very elegantly showed in his statistical presentation, when you have low volume centers, the confidence interval on trying to determine mortality or any of the other metrics that you might look at is so wide that it would take you several years in order to figure out whether there's really truly a difference. And what happens to all those patients during those several years?
Well, if you remember what he said, basically he implied that centers doing 300 or 400 cases a year should be the only centers by his logic. And then he said, well, I guess we could compromise at 50. So I don't know what the right cutoff number is, but I do believe that hospitals with robust quality assurance programs monitor what's going on. And if you are producing good outcomes with high quality, I don't believe you should be prevented from doing the procedure.
Thank you. I'm going to ask everyone to try and contain their questions to shorter, and also to try and contain your temptation to characterize what other people have said. They're standing in the room and can speak for themselves.
Carl Tomaso, Chair of the Writing Committee. In response to your question, if you look at that slide of the low-volume centers, there were a number of them that had zero mortality. But the highest mortality overall was also in those low-volume centers. And that's why the median became similar to the rest. But you had a lot of low-volume centers with the highest ODEs or mortality, or however you want to measure it. And that's the reason, as Dr. Sheehan showed the funnel plots, that at low volume, you really don't have statistical accuracy as to quality. And that's why we think a volume criteria is appropriate.
Thank you. We'll take these two, keep going, and then I'm going to take the next question.
Dave Sheehan, I just wanted to clarify something that Dr. Pelikan said. First of all, my comments related to the zero mortality program, that has nothing to do with volume outcome association. That's simply a random sampling issue. And we just know from the phenomenon of regression to the mean that if you're zero mortality, even if your actual long-term mortality is average, you're going to have a blip on the other side because you're going to fluctuate around the mean. It's the same reason a major league hitter that hits 350 this year and gets a gazillion-dollar contract, next year hits 175.
Don't remind us.
It's the same phenomenon, exactly. And secondly, I never quoted anything about 300 or 400 cases. Obviously, I said I could make a good argument for 100 cases as opposed to 50 cases just based on both the volume outcome and the statistical issues, but I've certainly said nothing about 300 or 400. Thanks.
Thank you. Dr. Goldberg.
Steve Goldberg, two comments. One of
affiliation,
which,
please. Sorry.
The Tyler Heart Institute, Monterey, California. Bringing it back, it is challenging to have these statistical discussions about volume and mortality and so forth, but we cannot lose sight of the fact that if that is going to have an impact on access of care, that the numbers are really not going to be reflective of how we're taking care of patients. So we cannot divorce those two things. If the volume requirements are going to reduce access to care, then that has to be factored in. The second point is I wanted to comment that's been made a couple of times today that in the TVT registry that the larger volume hospitals had sicker patients based upon the STS risk calculation, but in fact the smaller volume hospitals had older patients. And there are many features that go into the STS risk that don't go into the STS risk calculator because those patients tend not to be operated on. And those features, such as porcelain aorta or severe lung disease, increase with age. So it is maybe a word of caution that that specific analysis may be fraught with some misleading interpretations.
Thank you. Naftali?
I just have a few questions. May I ask them?
Mm-hmm.
So I just jotted out a couple of clarification questions. Dr. Pelikan, given the reduction but still resisting mortality, stroke, other complication rates from TAVR, such as pacemaker implantation, aortic regurgitation, Dr. Carroll mentioned before 22% serious in-hospital complications. Just a comment, I noted in your letter for formal request that you described TAVR that it's now become a safe procedure. And it was mentioned a couple of times in the letter, and I just found that to be somewhat surprising. Obviously, it's dramatically improved, but to call it a safe procedure is one of the things that I'm concerned when I'm involved with patient advocacy, that patients should be aware of the risks involved, even if they're decreased risks. The question that you noted that TAVR is not affected by procedural volume of non-TAVR procedures. So if so, I was wondering, your conclusion, you noted that you have recommended volume requirements for structural heart procedures. And I was wondering why you would recommend that, given the other assertion of TAVR not being affected by procedural volumes of non-TAVR procedures. Dr. Bavaria, I was wondering that.
I don't know. Sure, we'll do one at a time.
Peter Pelican, Santa Monica. I'm sorry, just give me a succinct question there. I'm sorry.
You noted in your letter, well, it's not a question, that's just a comment, but the question was that you had noted that the experience of non-TAVR specific procedures does not improve the outcomes. I believe you noted that non-TAVR procedures are not actually helpful in equating to improved outcomes. But in your recommendations at the end of the letter, you noted that the recommendation for requirements for structural heart procedures. And I was wondering why that would be if that doesn't actually help TAVR outcomes improve.
Okay, so I believe what you're, the answer is the following. I think in order to do TAVR, you clearly have to be, as the interventional cardiologist, able to do coronary intervention. You have to be able to do peripheral intervention and structural heart intervention. So I believe clearly you have to be competent and good at those things to do the procedure. The procedure, I can tell you from personal experience, compared to 5 or 6 years ago and now, it has gone from general anesthesia, 15 people in the room, a lot of anxiety, things occasionally didn't go well, to conscious sedation, percutaneous access, fairly streamlined, fast procedure. I'm not disagreeing with the quote of 22% in-hospital complications, but that really has not been the experience that I've had. But clearly, you have to be able to deal with a coronary emergency. You have to be able to deal with a peripheral emergency. My only point is, if a hospital does 300 or 400 or 200 coronary interventions a year, it doesn't necessarily make that operator better at doing those procedures. So I'm divorcing.
Oh, sorry. You answered the question. Okay. Thank you. Dr. Quickly.
Tommaso, Writing Committee Chair. In the 2012 document, there were no training programs. There were very few people experienced in TAVR. We put in prerequisites, having done balloon angioplasty, having done other structural issues. This document says if you want to do TAVR, you got to be trained to do TAVR.
Thank you. Aloysius?
I have two questions. First question I'll ask as a cardiologist. During lunch, I was trying to imagine, I'm a cardiac surgeon. I do 200 aortic valve replacements, but they're all elective. So my question is...
Closer to the microphone.
Oh, sorry.
Thank you.
I'm going to ask two questions. First, as a cardiologist, during lunch, I was trying to imagine, I'm a cardiac surgeon. I do 200 aortic valve replacements, but they're all elective, which is an entirely different scenario if you have a complication from TAVR and the patient crashes in the cath lab. Now, the technology for TAVR has really accelerated. So my question has to do with training. Is there any data on simulation centers to either help train people initially or to update or reassess skills at centers that are doing TAVR? Because we hear a lot about volume, but simulation centers can be a useful means of education.
I think Marty answered a little bit of that earlier regarding the training question. There are training simulators. They're actually quite good, and they're being used ubiquitously throughout the country, as Marty said, and he's probably 50% of them are done at Columbia. And both on the Medtronic device as well as the Edwards device, and in fact all the devices have simulators. It's been shown in the kind of the education training world that simulation is pretty good at the beginning of one's experience, but after a while, as Dr. Tommaso said, simulation doesn't make that much difference compared to real life scenarios. So that's actually a well understood procedural issue in simulation education circles.
Thank you. Do you have a follow-up comment?
Yes, I do, representing the surgical side of it. So for example, when I think about the complications that occur during transcatheter aortic valve replacement, rupture of the aortic root, all right? Our cardiac surgical trainees learn how to deal with that problem basically by doing root enlargements during elective aortic valve replacement or repairing aortic roots that are affected by endocarditis where the root is destroyed. So that's where people get the familiarity to deal with these, and every one of these complications will be completely unique. They need to be able to do root replacements, they need to be able to root repairs, root enlargements, patch repairs of things, that sort of thing. Does that answer your question?
Partly. But is there any data to assess the efficacy of simulation?
Not of which I am aware.
Okay. Second question I'm going to ask just relates to my population public health issue. I still can't digest the 3.8% rate of TAVR in African American populations in the U.S. given, and I'm dating myself, but I'll go back to the old Cabbage data where they used Medicare populations, one white, one black. So insurance was not an access issue, and utilization and recommendations for intervention and bypass surgery were lower in the African American cohort. So the issue is complex, to say the least. It's multifactorial, to say the least, but it has persisted, whether you're talking about Cabbage back in the late 70s, early 80s, or TAVR in 2018. The answer to the issue is not to increase the number of facilities doing TAVR. There's a more fundamental root question in how the healthcare system works, and that's more a comment than a question.
Great,
but I had to get it off my chest.
I apologize. Naftali, you actually had two questions, the second for Dr. Bavaria, so please, I apologize for cutting you off.
Yeah, that question was if mortality is indeed increased at low volume centers, and if there is really no concern of access, then why, you concluded by being very clear that you're not recommending for those sites to be closed down. So if you translate the low volume centers into an increased risk for those patients, why is that your recommendation?
I think there's two answers to that question. First of all,
sorry, name and affiliation.
Oh, I'm sorry. Joe Bavaria, co-chair of the writing committee.
Thank you.
Thank you very much, Peter. So we think we know for a fact, based on the most recent data out of the TVT database, that there is a volume outcome relationship, and that volume outcome relationship is quite significant at under 50 and very significant under 25, and you can see that data. So the question is, well, why not close them? Why not kind of close them down? As the four societies, our job is not to close down sites. Our job, regarding this kind of a document, which is a consensus care document, is to provide for remediation and provide the data so that sites can get better, as Dr. Carroll said. So you are right. The answer to the question is, if you're a consistent low-volume site who has poor outcomes, even though it's hard to measure poor outcomes, but if you do have poor outcomes, then there needs to be a process for remediation, a process for identification and remediation. And the societies are prepared to do that. Shutting down a program is not in the purview of the four societies, and since we wrote the document, that's not really in something that we would do. That would be a CMS issue. For example, when we do transplants and we're below a certain threshold of either quality or volume for transplants, we get a letter from CMS saying, they're not going to pay for transplants for a year or two until something happens. That's kind of a thing in the United States. So they can do that, but the four societies provide remediation, identification, remediation, don't shut down programs.
But the consensus position is that there is a concern for those patients that are ending up at those sites, that they're at a higher rate of risk than if they actually end up in a higher volume site.
Well, as I showed, someone even said it. In that data set that we showed, one site was a high volume site with very bad outcomes, and so we do have a few of those. And
Sure, but looking nationally.
Yeah. So
an average.
So I don't know. I don't really know exactly where your question is going. I would say that I would reiterate that the societies are not in the position of shutting down programs. And maybe John can say something. We are in the business of identification of poor quality, measuring poor quality and good quality, and then remediation efforts for the sites as best as possible so they can get better. John?
Briefly, if it's additive.
John Carroll, ACC. It's a great question. The TVT registry delivers to all sites on a quarterly basis their results with national benchmarks. And that gives the site an opportunity to say, how are we doing? Let's sit down, talk about how we're doing well, how we're not doing well, where we can make improvements. And we hope, because there is a learning curve and there is experience gained over time, that those sites will improve. But as Dr. Bavaria said, we don't have an accreditation process yet, any way of really bringing external factors to bear, and CMS hasn't done anything like that yet. But that should come as a next natural evolution in this treatment.
Thank you. Smadar?
So I just want to shift a little bit from outcome to access to care, which is another big concern that was discussed here today. And the thought of low-volume centers, just playing devil's advocate, those typically don't really have the infrastructure to allow for large volume of patients to get care in those centers. And I wonder if there is any data to show, to support or to negate low volume centers actually cherry picking the patients that they could accommodate and care for, and therefore still producing or contributing to a problem with access to care by sicker patients, minorities, etc.
Question is if there's evidence that that happens, right?
Support or negate that.
Aaron Horn, Association of Black Cardiologists. So I think we all agree here that patient selection is imperative, regardless of the center, right? So we definitely concede that. However, we obviously have a responsibility to treat whoever comes across our doorstep. And I think that what we have found based on the geography data and patients' preferences to actually seek care in an environment in which they're most comfortable and most familiar obviously impacts the way in which they get treated. And so while I agree, and I think we all agree, patient selection is imperative, and I think that also, I'm making it clear that I think some of these non-traditional centers, and maybe this is a misnomer, we actually do have the infrastructure to manage these things. We all have a heart valve team, and I think that some of the iterations that make it unique being in a community center, for instance, they have a surgeon that's done 50 surgical valves at that one center over a 12-month period of time. In the community, for instance, and where I practice, that surgeon actually does surgeries in 4 different hospitals, but has the same anesthesiologists that work across it. It's a different environment, and I think that actually is what Dr. Goldberg was mentioning before. And obviously we all came from large academic centers, but then obviously we were trained well, and now we're in the community and trying to make sure that we can bring that skill set that we learn in those environments to the patients where they are.
Thank you. I'm not going to, I want to get to other questions. I'm sorry. I'm sure I know there's going to be added, right, exactly. Okay. Thank you. It's being recorded, so it can't be just hand gestures. Sandy?
So it came to mind as we were talking about training centers and early challenges. Has anyone looked at the comparison of outcomes for training centers versus non-training centers versus small programs?
I think we'll take that as either no or no one here is aware of it. Oh, sorry. I didn't mean to jump the gun.
Megan Coyle-Wright from Dartmouth. I'll just provide a little clarification about the state of training for structural heart disease in the country to answer that question. We don't have accreditation for training for structural heart disease fellows, so Dr. Horn and I were some of the early fellows that were trained. These are unaccredited programs. There are not specific volume requirements that are applied. We look to the professional societies as well as Medicare requirements. When we train other fellows that come to our programs, we have to get funding from other spots to do that. So it's different than interventional cardiology training programs where this is an accredited program with national curricula and goals that have to be met and that are assessed. So for TAVR operators that are coming out of fellowship and when we're training fellows, it's an unaccredited program without specific guidelines. Separate from what Dr. Leon talked about where he's bringing in attendings that have finished their interventional cardiology training.
But those fellows generally have had an interventional year?
Yes, it's usually a second year of training. So the structural fellowships that are currently available are not accredited, yes. So they're somewhat individualized, and the curriculum is really based on the institutional ideas of what the curriculum should be, and there are relatively few of them. So you can count the number of defined structural programs probably on the fingers of both hands. So there are not enough structural programs to treat or to train new fellows that would provide an answer to some of the access issues that we've been talking about. It's difficult to get this training out of fellowship.
Great, thanks. Now I'm going to cut you off. Sorry. Michael. Sorry.
This is a question for my colleagues representing societies in that while the TVT registry has been developed and is doing a great job at defining outcomes of procedures, and there's going to be more to come from that, I'm absolutely certain. Have the societies given any thought to developing structured processes of external review of poor performing programs to facilitate QA, QI processes in those programs? Somebody mentioned the term remediation. That would be the implication.
That's a great question.
Name and affiliation.
I'm sorry, Joe Bavaria, co-chair of the writing committee. And also the STS for this particular answer. On the TAVR side of things, there is no structured available remediation effort to date. This is one of the things that's in the new document that needs to be created, and is one of the hopes of the new document and an NCD that possibly might ensue. Now, on the surgical side, on the STS side, there is some rudimentary remediation efforts by the Society of Thoracic Surgeons regarding remediation for one-star programs in the United States of America. But it's not, they have to ask the STS for that. It doesn't go the other way around. So it's kind of neophytic, but it does exist. And it's actually being discussed right now as we speak at the board level of the STS, whether that should be a little bit more robust.
Great. Dan, please. Sorry, no, I'm just going to let one answer per question. Sorry, Dan.
Thanks. So I've been kind of puzzling over the notion, and it's been brought up in a couple of different presentations around whether reducing or eliminating volume requirements would be either necessary or sufficient to address disparities. So Dr. Horn, I'm wondering if I can ask a question about the data you presented specific to your community. So it's a community with highly prevalent Hispanic and African American populations. Half the population is reported Hispanic, a quarter as African American. But the data you presented on the rate of TAVR in the African American population as being much higher than is typically seen nationally was impressive, but it seems as though the Hispanic population there is still underserved. So I'm just wondering if you want to comment on that.
Aaron Horn, Association of Black Cardiologists. So I think you're right. I think that it's a huge area that we need to look at much more closely. I think that, to Dr. Couillet's point, it's multifactorial. I think that when you have, and again, I don't want to generalize, but you have a component of the Hispanic population that, not all of them, but a percentage of them might have a language barrier. There might be an uncomfortability or a lack of awareness in terms of how to actually access the healthcare environment, and many reasons why. Just anecdotally, again, I got a phone call last night from a family friend who was sick, didn't know what to do, and we were able to facilitate getting that patient to care. So absolutely, I think that it's an area where we definitely need to spend more effort and energy. But I think that some of the systemic problems with regards to language barriers and their, in some instances, inability or uncomfortability with having to figure out how to navigate the healthcare system. And I think that data actually is supportive. If you look at, again, in terms of the African American community, if you look at, again, just we know that there is a correlation many times with income and education, right? So we showed the difference in the median income amongst African Americans and Caucasians, and their savings as well. And there is a lack of a wherewithal at times to figure out how to actually get access to information and care.
Can I ask you a follow-up question, even though I'm out of order? So the disparities that you described, that we saw a couple of other speakers described, are frustrating on many fronts, and you've listed some of the causes. But I'm just trying to look, this is disparities, particularly between whites and African Americans, have been long documented across many conditions, equally frustrating. The question I have relates to the volume standards for TAVR, and if we can look at TAVR and conclude that the volume standards have made the disparities incrementally worse than they are sort of ambiently across all parts of healthcare. And I'm not trying to discount the importance of them. It's a causal question. Are we sort of worse off with TAVR because of these volume requirements than we are for traditional cardiovascular care or open heart surgery, or I focus in cancer, and massive disparities there as well, where we don't have volume requirements. So do you see a bigger effect? Is there a difference?
Unfortunately, I do. Because again, we have demonstrated that patients are only going to access care where they're comfortable, right? And we, have the trend lines that show that some smaller programs have had adverse outcomes. Obviously, it's somewhat personal. I'm pretty proud of the outcomes that we've had. So some small programs actually, I think many of us have great outcomes. And again, if you're going to offer the patient nothing as opposed to being in a more familiar, albeit less robust, maybe critically acclaimed national environment because of the way where your physicians practice, I think that the patients, again, in this era of shared decision making, should be able to have access to that information. Every physician has the right to be transparent with their outcomes. I tell everybody we're a small center. We've done X number of cases. These are our outcomes. And I think that they deserve the opportunity to make that decision.
Thank you. I'm trying to get to the other questions, even though I inserted my question. Mark, and then Aloysius, and then I'll give everyone a chance to say something if they think it's a burning issue.
You can tell me after the meeting, John. I'm going to ask what is certainly a naive question, and it may even be outlandish. There's been the assertion, which is understandable, that it's difficult, if not impossible, to measure quality accurately in low-volume centers. And when we talk about volume, we're talking about not just volume, but volume over time, specifically annual volume. And my question has to do with what is magical about a year? Why not 2 years? And should we be focusing on time at all, or should we be focusing on the absolute number of cases that is required to assess quality, and then assess it at that point going forward repetitively? Sort of like your oil changes in your car, every 5,000 or 10,000 miles. It's just not clear to me why 1 year should be the answer.
Because that's how long it takes the Earth to go around the sun.
Sorry, I couldn't hear you.
For serious answer now.
Dave Sheehan from STS. Well, you're absolutely right, and we're looking at a running 3 years is probably what we're going to settle on, just to address that particular issue. Your point about just doing, if you think you need 150 cases in order to get a statistically valid result, why don't you just wait till 150 cases? It's an option. I can't think of any situation which that's been done, and there may be no good reason that it's not been done, but it is.
So there might be some centers where you would measure that at 6 months.
Yeah, that's right. But just to point out some other ways to mitigate this small sample issue, on the surgical side, we've gone to composite measures. And just to give you a very quick example, in the development of the cabbage composite, the STS cabbage composite, using mortality alone, which is what we're basically been talking about today, we could identify 1% of providers as being outliers when we first did this. When we went to a composite that had more risk-adjusted mortality plus the risk-adjusted occurrence of any of the 5 major complications, we could identify a total of 23%. We've seen the same phenomenon in aortic valve cabbage composites. So that's a very powerful tool for making it possible to address quality and measure quality at lower volumes than we have historically with a single measure like mortality. And we are moving towards composites in TAVR as well. Thanks.
Thank you. Anita.
So this has been a really informative and educational discussion for me. As a health disparities researcher, I really want to challenge my colleagues around the table, as well as those of you who sit in the audience, and those who are on these decision-making boards and committees, to really rethink how you are equating quality with volume. It's very, very antiquated. You are sitting in existing committees and boards where you are vested in and focusing on volume. There are research methods and strategies that exist that where gold standard does not have to be focused on quantitative statistics. There are strategies where you can think out of the box and think creatively about meaningful outcome data. Volume is not an outcome data. What are you going to actually extract from a volume number? What is that going to tell you about how your patient is doing, what their quality of life is, how other social factors are being influenced and influence your patients? I really am looking at this very, in many ways, homogeneous group of folks here who are not used to thinking outside of the box and who can exist in their worlds operating this way until death do you part. But I would really, really challenge you to go back to your committees, work with your colleagues, bring in folk who have different views and different outlooks and perspectives to be able to treat what is becoming more and more a very diverse and heterogeneous patient population.
Yes, please.
John Carroll, ACC. Totally agree. This MEDCAC is focusing on volume. That's CMS's decision. And that's why you've heard so much about volume. Quality and this broader definition of quality is very important. And in the TVT registry, that is one of the main reasons we instituted getting this patient-reported health outcomes survey done in all patients before 30 days and 1 year to look at what is the treatment effect in all of the diversity of patients in terms of not only being alive at 1 year, but feeling better in their own words, to be more functional. that's why we're also looking at rehospitalization rates and whether people go home after a procedure or go to a nursing home. So we are trying to look at much more patient-centric ways of looking at therapy outcomes than just complication rates, et cetera. It's really about the benefit that's accrued. So I think we're working on that, and it's a challenge because no other clinical registry has looked at one-year outcomes having the patient's voice as a key component of what defines success. So you're totally on board with what you're thinking.
Thank you. Naftali, did you have another question? Your card's up.
Yeah, I just want to ask Dr. Leon.
Please.
So, Dr. Leon, I looked at a couple of the articles that you've published as part of the broader literature on this topic, and obviously, everywhere you look, see your name. And there were a couple of specific things that stuck out when I was reading through them, where you noted in one article in the Canadian Journal of Cardiology, to quote, "It's not surprising that several sites have demonstrated the effects of a learning curve. Experience has shown to affect overall outcomes and specific procedural elements." Then in a Jack article, you noted, "In parallel with technology enhancements, patients have benefited from increased operator experience. A large meta-analysis from 25 multi-center registries and 33 single-center studies found an important reduction in strokes after TAVR. These findings were associated with increased operator experience, the importance of operator learning curves and experience. Unlike other commonly used interventional technologies, for example, you noted stents, TAVR expertise requires intensive device-specific training. So in your opinion, what is the current learning curve, the amount of procedures for TAVR in less complex as well as more complex procedures that you were indicating in those articles?"
Thank you. You quoted several manuscripts that were in very different time domains as well. I think your points are very well taken. There's no question when you start a new technology like TAVR in the highest risk patients, which is what the original approval indications were, patients who had significant comorbidities, devices that were particularly high profile, as I mentioned earlier, in the early days, 30% having transapical access because you couldn't use a transfemoral approach. Certainly, there's going to be much more of a learning curve under those circumstances. So I would characterize the early days versus the modern era of TAVR, where many of these procedures are done in a minimalist way, where crowd wisdom and group learning and experiences over time have dramatically reduced the learning curve for new operators. So new operators being trained now have a much, much more shallow learning curve than we had 5, 8 years ago when we began this process. And it's for the very reasons that I mentioned. We do as a group have much more experience. We train against complications to prevent them. 95% of the patients have transfemoral access. We've been able to reduce sequentially many of the specific complications by a combination of procedural changes and technology advancement. So I think the learning curve issue, albeit a very important one 5 years ago, is less significant now. I can't give you an absolute single number as to what is the learning curve of a new operator who's being trained in TAVR. Certainly, I think you'd want somebody who's had good experiences with 25 or 50 cases as a primary operator under supervision. I think that would probably encompass the important aspects of a learning curve, and as being part of a much larger group with more experience in the other disciplines required to achieve optimal outcomes.
So you would require that amount? Would you feel comfortable?
I would feel comfortable, yes. The people who have proper proctoring with intensive training and had independent operator experiences of 25 or more cases, certainly, yes, I would be comfortable.
I just want to note that Jack article is from 2016.
Yes, but it reflects data that was accumulated from 2012 to 2014.
And was probably under peer review for 2 years or something.
Exactly. Fair enough.
That's the end of the panel questions. A couple things. Larry, I cut you off, and you haven't said anything, and so if I didn't, and also you had a comment you wanted to make. Anyone else, if you have comments, they are concise, they are additive, they don't mischaracterize anyone else's comments, we are open to it, but otherwise, we will be discussing things. And I will tell you, it is acceptable during our discussion that if we are wrong on facts and you have input, we would love to hear it. So.
Just a quick comment. I think one of the challenges here is we keep looking at TAVR in isolation without understanding there's a competing therapy for these patients, which is surgical AVR. Closing someone's TAVR program without understanding that their AVR program is much better does not necessarily benefit these patients. The idea that if every patient who's a TAVR patient leaves a hospital that got closed down and they go down the street and get TAVR is a false narrative. Most of these patients are going to end up staying at that hospital and potentially having surgery, and unless we evaluate the quality of how aortic valve replacement is done, then we're missing the forest for the trees. And so to deal with the sample size issue, one simple solution is to capture all of the patients' AVRs that are done and measure their OE ratio on how they did all of their AVRs, combining surgery and TAVR. It would give you a larger sample size and would provide patients with what they meaningfully want to know is how well does my disease get treated at this hospital and do I get proper care? Thank you.
Thank you.
I just wanted
Concise and new.
Yes, Joe Baveri, co-write here. Dr. Court's question was a good one, and I just wanted to, you wanted an example of some data, but nobody gave it to you. So one of the things that what we see happening regarding, these low volume centers, et cetera, and how they relate to higher volume centers, and that bit that you were talking about. When you have these large, like HCA, or say, for example, the big Cleveland systems, and even in our system at University of Pennsylvania, where we have about 10 hospitals that we own. So what's happening there is no really data, but the health systems themselves are dealing with this. So you have 10 open heart hospitals in your system, but the CEO says we're only doing the TAVR in 3, but the other 7 have TAVR programs up to the point of the procedure and then send them in a spoken wheel fashion. So it is being addressed. It's being addressed in an interesting way, mostly by the burgeoning of the large healthcare systems and taking care of the efficiencies of that healthcare system.
Thank you. Name and affiliation.
Robert Cabedo, Cleveland Clinic, Florida. I want to believe that the NCD guidelines and recommendations in 2012 were really developed in an era where structural heart disease was recently just introduced, where operators in different hospitals really didn't have any kind of credentialing recommendations and guidelines. And so it really has helped tremendously the commercialization of this therapy. I think it has evolved dramatically, and I think it's very important that we're making the next step to update, the guidelines, and I do think this is a very important day for all of us, including our patients. With that, I'd like to say that when we revise and when we come up, or when the panel does, I just keep in mind the things that have been discussed today, the ethnicity considerations, the geographical considerations, and the training consideration. If I were to take Dr. Marty Leon to my hospital today, he could not do TAVR. That makes no sense in my mind. If I could take any of the surgeons that are sitting in the front row to my hospital today, they could not do TAVR. And yes, we heard that the question asked in the office is, well, what's your experience? But my question is, what sense does it make for me to jump on a plane and go up to New York, go up to Boston, or drive 60 miles when you alone have trained in structural heart disease, have all the structural heart experience across the board from Watchman and PVL and closure and ASDs, and we do heart transplants in our hospital. So there needs to be a careful examination at the volume and the metrics of quality, but there also, because I do think there is a need for some volume metrics and quality metrics, but there has to be some consideration to exception. So what was said, that if you're formally trained and have all the experience, you can do TAVR, is not true. I'm held back by PCI volume. Other colleagues of mine are held back by AVR volume. So if I were to take any of the folks that have intervened today, and we park them in a hospital that does 350 PCIs or 25 AVRs, that in and of itself excludes them from providing care to many of our patients that are asking for valve replacement. Thank you.
Thank you. Now I'm going to cut it off. All right, sorry. I apologize. We're going to move on to thank you for all of your answers to the questions. I'm going to we're going to move on to a discussion amongst all of us. This is also open. As I mentioned, we are all seeking input and insight. And so during the course of this discussion, if things that come up that are factual in nature, please, I'll figure out a way to integrate you into that conversation. But I want to ask, I will start this, but the panel all knows that they're supposed to speak to one another, to ask one another questions. I'll start with the central issue. At this point, based on the observation of the data, there's strong feelings that there is not a volume signal with relation to mortality. I think that was a triple negative, but those are in vogue now. I'll say it again. Is there a solid conclusion that there is a volume outcome relationship with TAVR based on the data you've seen today? That's the question to you guys. Or what are the remaining questions that we need to tease through?
So I've sort of been teasing this question in my mind, and when I think about going down to a site doing one or two of these, that to me makes me nervous. I don't like that. It seems that emergencies come up, teams work well together when they've worked on a project together, but what is the right number? Is there a right number? And is a number important at all? We certainly have numbers for credentialing in PCI. You can't do PCI in my hospital unless you do a certain volume.
Right. And to remind everyone in the room, as well as the panel all knows this, the discussion we are having is about volume essentially conceptually. It's obviously numerical, but not about a specific cutoff, like is it 25 or 50 or 100, but it's a directional. So your answers seem to come from less of a statistical place than it came from clinical experience and expertise and observation. Is that fair?
That's fair.
Okay. Please.
I'd add that when you look at the data, the outliers, the unfavorable outliers, are clearly in the low volume patients in the low volume centers with rare exceptions. I think I would bring in something else. I'm a pilot, and there's probably no organization that's more wedded to outcomes than aviation, or very few. And they, in fact, look at, partial answer to Mark's question, they look at time and number of various maneuvers that are required to maintain currency. So every 6 months, at least the rules used to be, that you do 6 hours of instrument flying in actual conditions or simulated, and 6 landings. And that's just an example, but the idea is that you maintain competence as a factor of volume. And while I can't prove that that's what's led to a linear decline in flying accidents, it's certainly been a significant part of it anecdotally.
Dan, go ahead.
So I will take the statistical view, because that's all I can do. And I guess I went into the day knowing, as I do, having looked at evidence for a number of procedures in a number of disciplines, and I know that Dr. Bavaria and I think Dr. Carroll in their comments noted this. There's been a demonstrated volume outcome relationship for a number of complex procedures across a number of disciplines, cardiology and non-cardiology alike. So I felt like I needed to be convinced that there was not a volume outcome relationship, and I don't feel convinced that there is not a volume outcome relationship. Now, all that being said, this is not what we're voting on today. A volume as the only surrogate for quality also makes no sense to me. There have to be other quality indicators that could be part of a true comprehensive program to understand what a qualified center and what a qualified practitioner looks like. But there was nothing in what was discussed today to tell me that there is definitively no volume outcome relationship.
Please.
So not only am I struggling with the volume index, but I'm also struggling with this. We seem to be very focused on mortality as the primary outcome. It is important, obviously, but I think that there are other variables that also need to be taken into account that have not been examined.
I think, just to clarify, I think some of the outcomes that we saw on those slides included things like stroke rate and other sorts of complications, as well as mortality. I might be, please correct me if I'm wrong.
Also, as a behavioral scientist, I'm also interested in other social behavioral variables other than, you know, stroke or related illness.
I wasn't disagreeing, I was just clarifying what we did look at.
So my disclosure is that I'm not an interventionalist. I'm an imager. I'm the director of the echocardiography laboratory at Stony Brook, as well as the Valve Center and non-invasive imaging. To maintain my level 3 in echocardiography, I do need to perform certain number of and read certain number of studies a year to keep my lab accredited as it is, because I highly believe in lab accreditation and high quality imaging. I do need to demonstrate that each one of the physicians who work in my lab is actually reading and performing a certain number of studies a year. I'm also part of the structural program at Stony Brook. I'm actually the only person who is involved with those procedures at Stony Brook. And I came here this morning thinking that this should really not be any different, and there should be some volume. And again, not saying what that volume should be, but there should be some volume requirement to start a program and to maintain a program. Obviously, and listening to some of the things that were so elegantly said today, I also believe that there should be some provision for deviating from that requirement based on expertise in the place where the program is to be started, as well as geographic limitations. So I would have loved CMS to look into those criteria as well and add those in addition to a volume requirement.
Patrice Nickens, also no conflicts. You know, so I agree with all that has been said, but it's really quite frustrating. It feels like we're somehow in this framework that doesn't seem to work well for the importance of, this is a game changer, such an important advance in this field. And, you know, volume, as we watch cardiovascular disease, death rates decline, and we continue to do well, you know, volume is not going to be a practical way of assessing much. We need to do better, because that's exactly what we're trying to decrease, our need to do these procedures, et cetera, et cetera. So I guess my fear is that we can answer these questions fairly well, because there's a certain threshold below which wouldn't make sense. Of course, you have to know you have to have some experience with this procedure in order to have good outcomes. But it does seem that it is centrally driving the value of this procedure, and that's wrong. And it also doesn't allow the fact that this kind of determination impairs access, which, again, I guess worse than not having volume is not even having access, not even, never having a chance for the procedure, which also is another way of biasing outcomes. You're only doing the procedures on the persons that have access to it. So I hope that there's a way that in going forward with this, that we have an opportunity to point out just how thin, while perhaps a necessary condition, how insufficient volume is to assess this very important breakthrough technology, which we expect to continue to improve in the future.
And Patrice, may I ask, and I'm not trying to ask a leading question, so if you hear leadingness in it, please don't. You talk about other metrics. I guess the question, it comes back to this we are supposed to be discussing volume itself. are you saying that these other metrics are superior, but volume is still something that matters, or that these other dimensions are really where all the focus should be, and that volume should be, left to the wayside?
So I thought I understood the this national coverage decision process, but we've talked about competencies and learning and then evaluating teams and their quality, and I'm trying to make sense of what we're trying to do by allowing a procedure, hospitals to be covered. I mean, this decision will affect whether or not programs are able to, to continue, or how they struggle to continue. And and again, it seems that volume, it certainly is an only indicator, is maybe not correct.
Thank you. Dan.
Just wanted to throw thought into this discussion, because this may represent a factual statement that somebody could correct if I'm getting it wrong. I think someone said that, so the access issues are multifactorial, and there may be, a volume requirement may be a contributor to access issue. We don't have a lot of empiric data on this, but there was a statement made that the rate of TAVR is higher in Wyoming, which has no TAVR centers, than it is in Illinois, which has 19. So residents of Wyoming are going out of state and having TAVR at a higher rate than residents of Illinois are having TAVR, whether that's in state or out of state. So access issues are critically important, but I don't know that we can explain everything relative only to the volume requirements.
So I don't know, but I would imagine that difference that you're talking about in Wyoming has to do with income and ability to go. So these are actually elderly, for the most part, elderly patients, but being able to plane out over to where a place to have a procedure like this would not be an option for underserved populations.
Yeah, and I don't know how the income disparities play out between the two states, but that was certainly a striking data point for me.
Have you ever been to Jackson Hole, Wyoming?
Yeah, thank you.
It's incredibly wealthy.
I haven't, but it's not the only city in Wyoming.
Yeah, so I mean, I think you have to look at part of what I think is disturbing.
I'm sorry.
Can I just say something about just the assumptions being made?
Yes, I know. All right, so I'm sorry. We have to have a process. I made the statement that factual corrections were more than welcome, but the time for, all right.
I have a factual correction. The data.
Ma'am, you need to introduce you. Need to.
You also
okay,
have to
I'm
say
Sue Peshin, and I'm with the Alliance for Aging Research. Yes. The data that's been presented at this meeting is it's blinded. We don't know anything about the specific facilities. They're being presented in sort of like and I don't know if you all have seen behind the scenes, that this is the listing of the facilities.
Yes, but in fairness, this isn't a factual correction.
It is, because you guys are making assumptions based on not knowing the specific facilities that we're talking about. And the TVT registry doesn't reveal that information.
That's a factual statement, but I'm going to cut you off. I mean, we have to, I'm sorry. Like, the time, this is uncomfortable for me, but that's,
Can I just make, Dr.
No.
Bach, can I just make one more point about this whole thing, which is that the weird thing I think with volume that's going on is they go through massive training, and there are minimum requirements to start a program. They should have high quality from day one when they start a program. The very idea that you need a certain amount of volume is basically saying that it's a learn-as-you-go process. And I really hope that's not the case.
Thank you. Naftali.
I think that one of the challenges that was mentioned today, and I think that there's broad consensus across the board that if there were other quality metrics available, if we can actually state what the outcomes data, risk-adjusted, from each hospital is based on outcomes rather than volume, I think everyone agrees that that would be preferred. The problem is that, first of all, that's not available, to date at least, publicly, for sure.
Let him finish his sentence, please.
Per hospital across the country? Reported to the public?
Reported to each hospital.
To the public, I meant for patients, right. So until that information is available, patients are blinded in terms of determining where they should go for treatment. Volumes is one of the comforts that they can have, that they know that the hospital that they're going to has at least that metric in place. So while I think that the other metrics would certainly be very valuable and perhaps better than what's available right now, until that happens, I don't see how we can cut that away from the patient in their decision-making process. The other side of that coin is that, as was stated over and over again today, when you have lower volumes, then you can't provide those that other data. So I don't really understand how it's argued that we can move forward with these other metrics in lower volume centers if you're not able to actually quantify that data and risk adjust it in lower volume sites. And that's something that I'm not sure if it was addressed yet, but I haven't heard really an answer to that.
Thank you. Aloysius?
Yeah, just a comment. I mean, when I think volume, if I'm getting a valve placed, I'm going to ask the surgeon what their experience has been, or the interventionalist. But I'm also going to ask, I'm sorry, if I'm going to have an aortic valve replacement, not really, but just for the sake of argument, I'm going to ask not only the surgeon or the interventionalist if I'm having a TAVR, what your experience has been. I'm also going to ask them where the procedure is going to be done. Because one of the things that hasn't been discussed much is the team involved in the patient care. It's the RNs, the NPs, the PAs, the physical therapists, and who's leading the team. All of those things are important to me as a patient if I had to decide where I was going to have things done. So I think there needs to be, we focus very narrowly on volume for the surgeon, the interventionalist, structural heart person, but we haven't had much discussion about all the other components of the team. And I think that's extremely important in terms of patient experiences and patient outcomes.
Has to be facts.
It'll be fast.
Fact.
Fact.
Not FACT, not FAST.
I can do fact and fast. I'm from Alabama. I speak fast. With all due respect, doctor, you said this was all a play act, that you're a patient. You're not a patient. You have no idea what it's like to be told that you're going to have an aortic valve replacement. You have all sorts of questions. There are other things other than how many do you do and where did you get your training? That's not it. That is not the question that the patient is going to ask you. It's going to be other things. It's going to be, will I have to travel far away? I'm too sick to travel. Can I get it done here just as good as I can get it done there so that I will be here in my neighborhood where my family can be close to me? It's important to be with your family and have them with you when you're going through a procedure like this. I love my surgeons. I've been opened up 5 times, but I love my surgeons. I have them up on a pedestal. I also love my cardiologist. He is my hero, and my relationship with my cardiologist and myself, between the patient and the cardiologist, to me is almost a holy
Right. Thank you very much.
relationship. You're very welcome.
What I said was you need to do your homework and where you have things done in addition to the experience. I had a hip done. Believe me, I did my homework before I decided who and where it was going to be done. The other piece of it is travel's been mentioned frequently as a factor. We need to take a look at what some of the children's hospitals, they make provisions for families to be with their kids. Not always, but that doesn't mean we can't do it or make a recommendation that it be done. We did a study in Nassau County in Long Island called Vital Signs, and travel was at the top of the list. If people who didn't have neighbors or family to drive them took an hour by bus, half-hour waiting in the office to be seen for 15 minutes, and an hour to go back home. So it's not something that should be taken trivially, but it's something that we should think about alternatives to compensate for folks who are reluctant to go to a better place, if you will, because of the travel issues.
Yeah, can we talk? Yeah, can we talk more about this travel issue and this balance of access and qualification, and either with regard to the disparities that have been described or without regard to them? Where are people? How is this data that we've looked at, the maps, et cetera, being interpreted? Are there questions? We're soon going to have to ask this question of ourselves and vote on it, whether or not we believe, and we can look at the question precisely, but it relates to the volume thresholds as their effect and the trade-off, if there is one, between outcomes and access. So I thought it might help to talk about the data we've seen so far, if there are any views.
So,
please, Patrice.
Yeah, just a comment. So I don't think I reviewed specifically regarding TAVR, but there's a large body of information for minority patients that because of legacy of discrimination, that they feel a loyalty to, if you will, minority serving institutions, often despite quite high rates of poor performance, poor quality. And I just offer that as an example of a patient factor that if this kind of procedure, which is life-saving, is offered only at these quality high-volume centers, there's a large. Part of this would be education and other things, but it's the direct result of that is a large percentage of patients that would never consider moving outside the hospitals that treated their their relatives, their mothers and fathers and grandparents, because they couldn't go anyplace else in the past.
Yeah, I don't recall that we specifically heard discussions about limitations directly or examples related to access or had any data presented on that per se, but we did have data presented on time of evaluation, and I know that in our program, and I'm sure all the other programs have the same issue, the number of visits patients have to make to go through an evaluation process pre-TAVR, and certainly that would have a negative impact on access. If you live a distance from a program, the closest one you have available to you, or perhaps the quote best one that you have available to you, the number of times you have to return to that program would have a major impact on your ability to access the program.
Yeah, I actually think, did I hear the number 11 visits?
Yeah. Well, it's a lot.
Is that right? Well, what's you have a fact for us?
We have the fact. We've done this analysis, and the average TAVR patient has 13 to 15 visits before they have their TAVR procedure. And this is why it's not just traveling that one day of their procedure and their hospital stay, it's traveling for all the workups. And most hospitals do their own workups. They're not going to take other people's work. So this travel issue isn't a one-time thing, it's an ongoing issue.
Thank you. Fact.
Tommaso Writing Committee. I can tell you that maybe they're having 13 visits, but at least in our institution, they're doing 6 or 8 of them a day. So it's not like they're going back and forth 13 times. We compress it and get everything done in the shortest period of time as we can. So yes, they may be having 13 visits, but it's not 13 days.
Got it, thanks. It's got to be additive.
Yeah, the slide says it's from the time of diagnosis of aortic stenosis, not from the time of the decision-making process towards SAVR or TAVR.
Got it, thank you. Mark?
Are you interested in anecdotes or in the absence of evidence?
As long as we remember the plural of anecdote is not data, yes.
So I'm a native of Kansas, and I have a friend with a 95-year-old farmer, active farmer still, father, in Garden City, Kansas.
And he's the son is a physician in Kansas City. He called me up, told me that his father had critical aortic stenosis, and they were talking to him about this new experimental procedure, which is the one we're discussing today. So Garden City, Kansas is about 400 to 450 miles from Kansas City, or it's some distance to Denver where John Carroll would be, and it might be a little bit closer to Wichita, and you can get the procedure in all those places. But they chose to go 8.5 hours or whatever it was by car with a 92-year-old man at that point to the University of Kansas. And I think there were 2 or 3 visits before they made arrangements, but I can tell you, if it were not that his son was a physician, if it were not that his son knew me and I told him that this wasn't as crazy as it might have sounded, he never would have gotten the procedure done. Just never would have taken the next step. And there aren't many people in Garden City, Kansas, who have those kinds of connections to be able to connect the dots. And 8.5 hours is a long distance for a 92-year-old man who's having angina and lightheadedness and periodic bouts of hypotension. Thanks for enduring that.
Well, thanks. Sorry, I'm sorry about that. Go ahead.
But the question is that, do you recommend that there be a TAVR program in Garden City, Kansas?
I'm not recommending that, nor am I dissenting against it. But I think it's key to understand, as many have alluded to, the complexity of the issues that exist geographically. And I've heard that the density, and John, you might be able to address this, the density of centers in the United States is greater than anywhere else in the world. It wasn't clear to me whether that's density by population or density by geographic area. Population. So it's a much more complex situation when you've got a country the size of ours with populated areas and very rural areas.
Steve Goldberg from Monterey, and I just want to say is that your anecdote is my life experience in a larger area than Garden City, but that is a very, very common type of a scenario. And one small anecdote was a patient we decided was too high a risk for us. We sent them up to a major academic medical center a couple of hours away. They evaluated the patient, and I called to find out what they thought, and they said, "Oh, you didn't hear? He drove back home and died." And so I don't think that it's appropriate for an anecdote like that to drive things, but that is the real world.
Yeah, it's a severe disease. Thank you very much. Other comments on this access issue? Please, Naftali.
May I make a comment?
I'm sorry, the time for public comments is over. I'm sorry.
What I was wondering is, do we know that areas where there's, let's say, a 50-mile radius and you don't have a site available, and obviously for those that are elderly or there's other restrictions that's a barrier for them to travel further, do we know that right now that if the criteria was changed, that those are the locations where we would have centers opening up and not in the concentrated, saturated areas that we're hearing about over and over? And I guess you can't say a blanket yes, but in a marked way, is there going to be a dramatic improvement on that front in those areas? So,
yeah, that's a question of fact, right? We've saw a couple of maps with changes in standards and cutoffs changing centers that could be open. So is there an answer to that question?
Well, I'm just going to, Tommaso Writing Committee.
Yes.
I was going to refer you to the map I had with the red stars, which were the new programs that had opened in the last 2 years. 50% of them were in relatively rural, small urban areas, which improved access to care. The other 50% were on top of existing programs. If we had taken all of those programs and put them in the rural area, we wouldn't have had people having to drive 8 hours. But conversely, in those rural areas, like Wyoming, those people are used to driving.
okay, but obviously there are restrictions.
No, thank you.
I was just in Wyoming, in Gillette. They go to Billings to do their grocery shopping.
No, but given that there can be elderly patients that are not able to.
Let's have a fact check on that.
fact check on whether people like driving in Wyoming?
They do.
They do, that's fact.
But here's the fact. 50 miles is not the barrier, is not the only barrier. So in an urban center where there's 20 million people living, getting in and being seen and getting the procedure done is also a barrier. And if we have a small number of hospitals, I can tell you that where I'm doing TAVR is backed up sometimes 3 to 5 weeks to even get a date to do a TAVR because they're so busy. If we open up to low-risk patients, patients are going to have to wait longer and longer if we do not allow more centers to open.
Yeah, Peter.
Thank you.
I just want to agree with Peter. I practiced in Cleveland for 20 years, and there were people who would not cross the bridge over the Cuyahoga River, and there were people who would not go from one side of an interstate to the other. And there's nothing we're going to do to change that.
Thank you. Okay. Let's get back to facts. Go ahead.
Well, we can't really predict what would happen if more TAVR centers open, but you can have lessons from the past. And this was a story that I know I was involved with the proliferation of PCI centers. And there's a collection of literature that showed that once there were expanded indications for PCI centers, all driven by the need to have more STEMI centers, and then STEMI centers couldn't survive unless they did elective centers. They looked at what happened after that, and most of the new STEMI centers didn't happen in rural areas where they needed to provide MI care. They all happened clustered around existing centers because it was kind of a me too philosophy that existed. So I think the caution is if you open this up, are the new TAVR centers really going to be produced or open up where they're most needed? And we've heard over and over again that they're most needed in the Garden City, Kansas area and in other more rural areas or in other places where individuals have socioeconomic challenges.
Thank you. Dan.
I say we're not going to solve all this. I mean, I know the voting questions don't really solve.
Is your mic on?
I didn't turn it off.
No. Thanks, Mark.
Okay, there. So we're not going to solve all this because we could talk about locating centers where it's perceived that communities are underserved, if it's too much of a geographic burden, but that's not going to get rid of all the disparities. We haven't even talked about the gender disparity, which is plainly evident here, right? So women who need this procedure at higher rates are getting it at lower rates. So I'm just not sure what direction we're headed in. We need to acknowledge that disparities exist, and there may be remedies on the payment side, and maybe the societies can do something about this, but I'm just not sure where to go with this.
Great, thank you. Do you have another comment? Go ahead.
Just a comment. You know, we can identify problems, whether it's travel, loyalty to the primary care provider or cardiologist, but we need to think about what are collectively referred to as the social determinants of health. There are different ways to solve problems. One of them might be more TAVR centers, but that might not be the answer. We may need to figure out what people's resistance is, what's inhibiting them from accessing appropriate care, and see what the solutions are to the problem. That's not part of this discussion, but it's something we should begin to think about.
Thank you. Patrice, do you have another question, or is your card that's a legacy? I'm not the only one who should be asking the questions. Do you have questions of one another? With an eye to the next phase, I'm going to take you into a set of questions that are on the sheet next. So in this general discussion, do you have questions for one another? Okay. So all right, the next phase of this is, sorry, it's my OCD. The next phase of this is the voting. And so let me do two things. One is I want, because I think this is a rich discussion, I'm going to put things out of order a little bit, but which is that on the back half of your voting question page, you'll see what's called the additional discussion topics. We're going to actually start there, and we're going to discuss these issues in whatever fulsome manner we feel we can. These do not require votes, but the agency is listening to our conversation and trying to figure out a number of different things, including what is known or what our conclusions are about what is known, what the right next questions are. And I'll remind everyone that we are here discussing a national coverage decision that was called Coverage Under Evidence Development. It is a mechanism that CMS can use to gather more information at some level through the course of coverage. So we should keep in mind that we should lay out what we think the agency should go figure out. And they have a range of tools at their disposal for doing that. So we're going to start there, and then I will return with more instructions about the voting questions when we get to them. So to that end, these are specific questions. I think we've sort of covered them, sort of haven't, but I do want to go through the question on the table, which we've already started to ask, is do volume requirements create unintended barriers to TAVR based on any of the following: geographic location, gender, ethnicity, race, socioeconomic status, provider preference, which is explained in depth there but has been voiced several times. I trust my doctor. I want to go to the doctor or hospital I feel comfortable in, and the hospital setting. And so in no particular order or collectively, I want to start a discussion around this. And I've already brought it up a couple of times in a couple of different ways. The critical phrasing in that question is the verb create. Is it the volume requirements that create these problems? And I would say that in the counterfactual is, absent a volume requirement, these problems would certainly not vanish, or maybe they would vanish, but that's not what we're asking ourselves. It's would they be diminished, given the assumption that all of these gaps are bad. Let me ask, did anyone see any evidence that was overwhelming that they create any of these dimensions of problems? I could start at the other end, too.
I'll start. I don't think it's the fundamental issue. I'll go back to, I mentioned the Cabbage study. You can go to the 1995 New England Journal article where there was a conference, I think, with over 500 primary care providers. They had two sets of actors. One set was white, one at age 55, the other age 70. The other set was black, again 55 and 70 years of age. And the providers were given different scenarios describing anginal pain. The recommendations were less aggressive for the black patients and less aggressive for the female patients. So I think there's a fundamental issue, which again is beyond the scope of this conversation, but just having more centers, like it's the old build it and they will come, I don't think applies. I think if we really want to make meaningful change, it has to be a more profound analysis of what the issues are that inhibit patients from seeking care, whether they're legitimate, and if so, what are alternatives we can offer to them, and if they're not legitimate reasons for not seeking care.
Thank you. There must be other views on this, or similar views. Go ahead, please. Mike.
So I have benefited from a lot of education today from the various speakers plus the other panel members, and I would walk away from this saying there are unintended barriers to receiving TAVR care and a lot of other care in all sorts of other areas. That said, however, I don't think it's volume alone. I think I've heard a lot about different feelings that different groups have about where they want to get the care, and that's not solely a function of volume. I think that's a much bigger issue that's going to require really education for the whole community, or the whole body of patients that we've heard has severe symptomatic aortic stenosis, that many of them don't get the care because they probably don't realize how important it is, and that something can be done for them. So are there barriers? I would say yes. Are they totally related to volume? No.
Thank you.
I think that the word create is a very strong word. I think that volume can contribute to barriers for everything that is really listed there, A through G. but I would have used the word contribute as opposed to create. And again, keeping in mind that it's not the only factor.
I'll take that edit, even though I'm not allowed to edit the questions. I think the question is there a causal effect? And I think it's completely fine to use a softer term for it.
I think that Dr. Horn's presentation really highlighted the fact that you have these other very significant variables with the under-referrals, with the actual preference of patients not to seek treatment, which I think, just to echo, it really highlights the need for better patient education regarding what's available and what the potential outcomes are if they make use of that. And the fact that there's such a severe problem of under-referrals, I think, is another issue. That's not about patient education. That might be partially the referring physician's education. But these are obviously core components that are underlying those barriers to care. Is it possible that volume takes a part of this? Yes, but it seemed to be, based at least on the data that was presented, that it's secondary to other problems that are really much more reflective in the disparities that exist.
Thank you. Greg, are you waiting to say something? No? Okay, I'm sorry. I didn't mean to. Can I ask about gender? Did we see any data that volume creates or contributes to the gender gap that we saw today? Can I ask a factual question about gender because I don't know the disease literature well enough? Is it the case that the at-risk, the rate of women at risk or who are eligible for the condition would suggest a higher rate amongst women than we see? Yes? I'm seeing nods.
Yes.
Okay.
Demographics of the U.S. population clearly show women live longer. When you look at the proportion of 90-year-olds, it's like 60% women, 40%.
But is the prevalence of this particular valvular disease by age equivalent across genders?
Increases with age, and there's no gender.
Okay, great. Thank you for that clarification. So back to my question, did we see evidence that volume contributes or creates this gender gap?
No, I think that was the weakest of the parameters that are up there in terms of any potential correlation to volume. The question, but volume is almost certainly only one factor in whatever barriers might be set up by that. The other end is, would the patient, I don't want to pick on Garden City, but would the patient in an area that's far from a TAVR center really benefit from having a low volume center in terms of outcomes? And I think that's something that I think that remains unanswered.
Yeah, so one of the things I try to do is make sure we're all level set. So just to clarify, I haven't heard from anyone that they think volume is the only factor, right? So I think we all collectively are telling the agency what seems logical, which is that these are multifactorial things, but we are focusing this conversation, which everyone's doing a great job of doing, on this one particular operational question. I'm also not asking a question about magnitude, because I don't think we can easily get to that. But, you know, of course there are other factors. Factual only, please.
So, Aaron Horn, Association of Black Cardiologists. I guess specifically he said that he thinks that volume is a secondary issue in terms of the criteria as it's set up, but everybody on the panel has acknowledged that there's an underdiagnosis and an undertreatment of aortic stenosis in the African American population. And so by continuing to do the same thing, I think that that demonstrates that the criteria in itself is in fact creating as opposed to being a secondary causal relationship, right? Because we've shown over 5 years that that number has not changed from 3.8%, and we all agree that it's an underdiagnosis and undertreatment. So therein, I would argue that it is directly affecting it.
Thank you for that comment. To paraphrase, my characterizing them as independent factors, I think, is what's being objected to. They are interrelated factors over time, and I appreciate the comment. Socioeconomic status, just to go through this list, I'm trying to, in no particular order. volume standards creating gaps related to socioeconomic status? And again, not 100% responsible, but directionally. Please.
Just a
Patrice.
comment. As we go through these, you know, my reaction is to become increasingly dissatisfied with, so I think create is not quite the right way to put this, maybe contribute. But as we go through these, each of these, the answer, you know, is a little bit, yes, you know, sort of. And the more you go through these, you know, it's just, it continues a unintended barrier. If you need volume to have quality, to have these quality procedures available, all of these issues, you know, sort of create a choke point for each of these groups for different reasons. And if we continue in the same pattern where, you know, the geographic problems associated with volume are not, we're not solving. I don't see how, you know, how does it get solved by saying, well, volume has problems, but it's okay. And so, you know, I think it's clear that, you know, that the threshold number may be lower. I mean, we've had a lot of discussion about what good, you know, what the training programs require and why the numbers are what they are. And that, you know, maybe that's something that we could try to minimize. But nevertheless, it's that, you know, we're like defying the people preference. And that's probably not a good thing.
The point is taken. And remember, the agency is going to take into account our discussion around these things, including important points like that one. We're talking about SES. That's the topic, subtopic.
Yeah.
Okay.
Although I may throw in everything else too.
Get
Because
us home faster.
I think the frustration for me is that, so if we go back to the world before TAVR existed, all of these were barriers to good cardiology care. So there were disparities around all of these to good cardiology care. So I am still not even convinced that there's an interrelated association or contribution of volume requirements to either creating or exacerbating these barriers. I'm unconvinced. I think the way to try to deal with this is some sort of a demonstration project with some sort of volume requirements still in place around the other things that could be done to address, improve referral rates, improve education to patients and families, locate centers in underserved areas, geographically or based on race and ethnicity, and see what happens with that demonstration project. And then decide whether volume is a contributing factor or not. I can't think of it any other way.
Okay, thank you. Some other ones, I'm going to push a couple together. Not we should talk about each of them, but things like the geographic location, the hospital setting or structure, community versus academic, that those things that they're creating unintended barriers along those dimensions. Not a lot of discussion? Go ahead.
Well, I'll make two comments. One, if you look at the healthcare system, they're private systems, they're safety net systems. So you really need to map where patients are getting their care. And there's an economic underpinning with it. Before I shifted to administrative medicine, I was at a safety net, the safety net for Nassau University. What they're able to negotiate on reimbursement rates is much lower than what Northwell, which is the biggest healthcare system in New York State, can negotiate because they have the power of size and volume. So economics play a part in what procedures are done, the volume and the access. So that needs to be looked at. So where patients, you know, like when Northwell started an open heart transplant program, it was in Newsday, which is the paper for Long Island, and every other media access they could get, so it was really well publicized. Nassau University Medical Center, if they have any marketing budget, it's nowhere in comparison to Northwell. So the other factors that play into the dynamics. The other thing that's of interest for the folks from Harvard who developed the implicit association test, I don't know how many people are familiar with that. When I was chair of medicine at NUMIC, I brought the attendings in, directed them to the website, because everybody swore they had no biases. Then they took the test, and then we came back and we had a little discussion. There are other factors that people don't even consider that go into the decision-making process, both among patients and providers. So there's a whole universe of questions to ask and answers that determine. So this whole thing with volume as a barrier may or may not be, because it really depends on where patients are receiving their primary and tertiary care.
Thank you. And discussions, we've talked about race, ethnicity came up at one point as well. Happy to talk about that more. It's obviously come up as an issue. Generally, the panel sense, individuals on the panel sense about to what extent volume requirements contribute to or are creating disparities in TAVR access based on either, if I can lump them together, race or ethnicity, or both. I appreciate we've had a lot of discussion on this already, so I'm not trying to, this isn't causing a vacuum in CMS's records. Patrice, did you have something?
I was just trying to think in some of the solutions that were suggested today about many of the things were outside the realm of what this process would do. But when we talk about volume, we're talking about patients. If we put in patient characteristics, so there should be high-risk patients. There should be gender equity. There should be race, commensurate with the population. There should be, in other words, volume. Our centers doing this should not be able to handpick patients. I don't think that's ever intended. But if you look at the population that, if you looked at the numbers, and particularly that rise in the use of TAVR over time, which was looked, like the early days of PCI, and just, tenfold change in how many patients are being reached appropriately for this procedure. And when the minority participation in that rise was negligent. It was absolutely flat over the same period. So maybe, again, if we could at least ask that these issues, because disparity means that it's the health outcomes from one group is different from another group just on the basis of race. And so if you don't have access to these procedures, you are worsening the disparity. So there is a causal, there is that causal relationship, I think.
Thank you very much. Sandy.
The challenge as we move forward is that a lot of programs are nearly maxed out on their ability to perform additional TAVR procedures, so that as we look forward, there's got to be some consideration for where we're going to be. And it seems to me that volumes of AVR total is probably not something that's on our question list, but maybe should be thought about if we're talking about volumes, and ability to build new programs. If this procedure proceeds the way interventional cardiology has over the last 30 years, we are going to see huge demand that I'm not sure our current settings are going to be able to provide. There's a need for a hybrid room, a team. I'm not sure why there's still 2 surgeons on a team. Maybe there should be 2 structural cardiologists on a team. These are things we haven't talked about, but when we're talking about volume and the makeup of a TAVR program, I would think about these things.
Great, thanks. Factual, go
Point
ahead.
of fact, there are no data.
Name and affiliation, sorry.
Ted Feldman for
Thanks, Ted.
representing SCAI. There are no data to suggest that programs are maxed out on increasing volume.
Thank you.
Can I just add one
Please.
geography issue to the race issue, about which I have no specific expertise, but I built a TAVR program in Camden, New Jersey, which has a very large African-American population. And we noticed this disparity almost from the beginning. So I'm just saying it's clearly more than just geographic availability. I mean, I think Dr. Horn's slide showing the geographic issues are compelling, but it just is another sign of how there are many other factors.
Thank you, Zoltan. Yes.
So
Patrice.
something that Dr. Leon mentioned, that the penetration is very poor. And if we are, as we should need to be, more successful because of the improved outcomes with this procedure, it certainly suggests that we need to do something about education, et cetera, that this is underdiagnosed, undertreated, and that the procedure is probably underutilized.
Great, thank you. Okay, I'm going to draw this section to a close. I'm going to take an unscheduled 5-minute break because everyone's been sitting here for 2+ hours having to put up with me. When we get back at 3 o'clock, we're going to do the voting. I'm going to begin with instructions on how to do it. That's in 5 minutes. Thank you. need a mic.
So are you making it back? Are you making it back? You're going to get back?
Hi, we're going to get started, please. I know it's been a long day, but... Okay. Maria, are there instructions for using the phone thing? Does everyone know how to do that? Yes. All right. We're going to now do the voting. And let me just, a couple of things. One is we are using a new system. I don't get to vote, so I have no idea how to do it, but Maria's going to explain it, I hope. But let me say something about the voting. The questions cannot be altered. We can discuss them for points of clarification, and the objective is to have us all voting on the same question, all understanding it in the same way, and having CMS understand our comprehension of it. The other thing I want to say, and these things are difficult, I know, in many cases, but our goal is to do our best to refine, be accurate, and then everyone will get an opportunity to both, in fact, it's a requirement, to state your vote, as well as the electronic thing, as well as the paper ballot. It's a fully redundant system. But also to explain your vote, which allows to, if you will, add texture to it. I want to say something about some of these questions, and I won't identify particular ones, but you may find along the way that some of the questions feel like questions where we didn't get much today that helps inform the answer. And so I want to point out that it is perfectly okay to vote, and I'm not telling you what your vote should be, but to to measure your confidence in the statement, both along the dimensions of how you interpret what data you saw, as well as the absence of data. So it's okay, for example, to have relatively low confidence if you got no information. You have a chance to then clarify the origin of your vote after you explain it. So you could say, I voted this way because of X, or Y, or whatever X and Y is. That said, Maria, can you, our newfound technology thing?
Yes, so instead of using the clickers, we are basically the panel members, the voting panel members, they will be using either their smartphones or laptops to cast their votes. And once they cast their votes and everyone casts their votes, it's going to show up on the screen. So that's the only difference. Instead of using the clickers that we normally use in the past, because sometimes they get stuck and the vote's not cast, we've decided to try something different. So, and again, the scores will be available after the meeting.
Do they know how to do it?
Yes, I'm sorry. Panel members, there are instructions inside your folders. They're only for you. So you guys are the only ones with the instructions.
There.
It should be a blue piece of paper.
This one?
It says poll. It says polling closed.
Your smartphone, go to...
Go to that website. Does everybody have it?
Yeah, it says polling closed.
Yes.
Session. Says it doesn't exist.
You have too many letters.
T-A-V-S-O.
And yours is saying the same.
If you click on it, it'll say polling closed.
You're welcome, okay.
Then you have to go back. And it'll ask if you're sure you want to go back.
Then you have to go back and do what?
We may need to go back until she opens it up. I don't know.
Everyone has it with us.
There it is now. So the poll should be open. So all you guys have to do is just push the button according to your vote. Just push it. Do not hit enter or next. Your vote will be highlighted.
Okay, so I'm going to read the first question. You can enter it electronically. Please record it on your sheet. I will then poll you one by one to both ask your vote and if you want to add any context to it. Okay, so the first question is, but before you vote, if there are questions of clarification around the question as stated, please voice those. First question is, how confident are you that there is sufficient evidence that a certain threshold of SAVR procedural volumes must be required for hospitals without previous TAVR experience to begin a TAVR program.
So for clarification, that means you believe there should be a threshold, not the number, and you don't believe there's any fixed number, just that you believe there should be a number.
Yes, you can believe there's a number, fixed number or not. The question is, if you will, a directional one. Do you believe that there should be sufficient evidence that some threshold should be required? Is that everybody?
Yeah, we're waiting for one more person. There we go.
Great, that's everyone. And I'll start at the end this time, and I'll just try and fluctuate. Patrice, you state your vote, record it on the piece of paper, and if you want to add any explanation, you can. You're not required to.
No,
We
so
We can't hear you. I don't know if that mic, is
Yeah.
that the mic that's broken? Okay, thanks.
Yeah, no, it's working. I voted 3. I do think that some threshold is important. I don't think it should be an only, it needs to be qualified.
Thank you. Mark, and just to clarify, Mark's vote does not count for the scoring, but his views are still recorded and his vote is still heard.
On this one, I voted
Oh,
one.
I'm sorry, it also, Patrice's, I'm sorry. Go ahead.
I'm sorry?
Go ahead.
Okay. On this one, I voted 1. I did that because I didn't see evidence that there was a correlation for SAVR and TAVR, and I also heeded the warnings in 2 or 3 of the presentations about the perils of being a patient in need of aortic valve replacement who appears in December to a hospital that is seeking to make the threshold for SAVR and already made their threshold for TAVR.
Got it. Thank you, Zoltan.
So this is why we have a panel, I guess. From my standpoint, it wasn't a number, but just that for the kinds of, for what you need a surgeon for to start a program, without hard evidence, I nevertheless felt that there were plenty of data on surgical competence and volume, and so I thought there was a high level of evidence that to start a program, you need at least some reasonable volume of surgical experience.
What was your vote?
I'm sorry? I was a 5.
Okay, great, thanks. Dan, and please keep your answers concise.
So I voted 4 because I do agree that there is evidence that a threshold of procedural volume has to be required, and with a hospital without a previous TAVR program, I felt that SAVR was the closest proxy, but because it was a proxy, I didn't go for a 5.
Sandy?
I voted 3. I didn't see a lot of evidence today about SAVR volumes and starting programs, but I have this sense that somebody should know their way around the aorta to be involved in a TAVR startup. So answering the question of sufficient evidence, I wasn't convinced that we saw a lot of evidence about this.
Thank you. Smadar?
I voted 5. I still feel that to start, and I think that there is enough data to show that to start a TAVR program, you need to be in a place that knows how to take care of sick patients with severe aortic stenosis and take care of them in the cath lab or in the hybrid OR if something does happen and surgical intervention needs to take place. And that includes also the nurses and the technicians and everyone around who takes care of these patients.
Naftali?
I also voted 5 for similar reasons. First of all, that with the new TAVR program, the background and experience of the surgeons certainly can be useful in situations where things do go wrong. Obviously, that happens less and less now, but I would want the patients to have the confidence that that's in place as a safety net in case that occurs. And also, from the team approach, that One of the things that we saw with volumes is that it's not always the volume of the individual physician, but the hospital as a whole, because of their experience when they have more volumes. So I think that that would be a practically helpful as well to have that construct in place when the TAVR program begins.
Thank you. Anita?
Based on the evidence presented today, I voted a 1.
Greg?
My vote was 4. I think the key phrase is sufficient evidence. I think we'd all be very comfortable voting if there were multiple randomized trials that told us what exactly number we should use, if it's 50, 30, 100, but we don't have that. Failing that kind of evidence, I think it's important to fall back on the opinion of experts, and fortunately we do have such a document that has been crafted, and I put a lot of weight on that. I know if I had some dreadful disease and there was no randomized trial that really defined my therapy, I would be grateful for what the advice of a panel of experts, and we have that, and I think there is, using that as the standard, there is sufficient evidence.
Okay. Michael?
5, SAVR is an important component of any aortic valve treatment program, and a certain volume threshold should exist.
Aloysius?
I voted 2. I haven't seen any evidence that surgical replacement of aortic valve correlates with outcomes in TAVR. So that's my vote.
Question number 2. How confident are you that there is sufficient evidence that a certain threshold of PCI procedural volumes must be required for hospitals without previous TAVR experience to begin TAVR programs? Any questions of clarification? I'm going to guess there aren't, but if there are, no, please go ahead and vote. We're done. Okay. Aloysius, please. Oh, sorry. You're doing your... Wait, did you vote?
I lost no response received, so question?
Do we have everyone?
Yes, everyone, the voting is closed. Everyone voted.
You voted.
I guess I voted. Again, low confidence again, because haven't seen any evidence that the volume and experience of PCI procedures correlates with TAVR outcomes. I mean,
you said low confidence is a 1, right?
Well, 2. I voted.
A 2. Okay. All right. Thank you. Make sure you Please make sure you also document your votes on the yellow sheets. You might as well do that right now so that nobody, because otherwise we'll lose track.
Yeah.
Michael?
4.
Greg?
Almost the same rationale as my previous answer. I voted a 4.
Anita?
Again, based on today's evidence, 1.
Naftali?
I voted 3, only because specific to PCI, there's the other option of other proficiencies for procedures other than PCI that were discussed today. So if PCI was the only criteria, then I would lean more on the side of a 5, but I took a more moderate approach because I'm assuming that that's not the only metric that we're going to be looking at.
Thank you. Smadar?
I voted 5 for the same reasons I mentioned before.
Thank you. Sandra?
I voted 4. The reason I didn't go to 5 was that I didn't think that we heard a lot of evidence today, but on the other hand, I have had a patient who broke a piece of calcium off the left main during a procedure. I've had several patients who've needed both PCI and valve implantation, so the skills are in the background material.
Thank you. Dan?
I voted for very similar rationale to last time. Not a perfect proxy, but a proxy nonetheless.
Zoltan?
4, same rationale as Naftali.
Mark?
1, similar rationale. I didn't see data that established a clear correlation.
Thank you. Patrice?
Yeah, I voted 2. I moved more away from feeling that there was good evidence for this.
Great, thank you. And I'll remind everyone, please record your votes on your yellow sheets. Question number 3. How confident are you that the benefits of meeting procedural, that is SAVR or PCI volume requirements to begin a TAVR program outweigh the harms of limiting access to TAVR to only hospitals that meet volume requirements? Okay, the mean is 3.11. I'll start at the end, Patrice.
Yeah, I voted a 2 for this. I do think that the risk-benefit is really questionable.
1, I didn't see any data that really compared this and looked at an association.
5, this didn't ask about evidence. This asked about how confident we were. So I thought it was a little easier to answer.
Dan?
I voted 5.
Sandra?
I voted 1. Certainly the experience at Cleveland Clinic, Florida stood out in my mind for what we heard today.
Smadar?
I voted 3 for this one. I was torn right in the middle.
Naftali?
I voted 2.
Anita?
I voted 3 because the question did not ask about evidence per se today.
I voted 3.
Michael?
4.
Aloysius?
I voted 2 again with the same reasons for questions 1 and 2, and the technology is advancing, and if the system worked as well as it's supposed to, we wouldn't have the disparities, gender and ethnic.
Great, thank you. We're going to move on to hospital requirements. Are there any questions from the panel about any of this process? Okay, we're going to move on to hospital requirements to maintain a TAVR program. Different domain of questions. Number 4, how confident are you that there is sufficient evidence that a certain threshold of SAVR procedural volumes must be required for hospitals with TAVR experience to maintain their TAVR programs? Okay, Aloysius?
I'm getting boring, but 2 again. Same reason I haven't seen any evidence to support the question.
5.
In the microphone, sorry.
5.
4.
5 with the same rationale.
Anita?
2.
I voted 3. I think that as the TAVR program grows, the SAVR volume is expected to go down, and that should not be a reason to close programs or not meet requirements.
I voted 2 for the same reason.
Dan?
I voted 4, using logic basically symmetrical to starting a program.
I voted 5 based on the surgical data and also with the understanding that the actual number of the volume may decrease, but that there should be some threshold.
I voted 1 because if quality cannot be accurately measured in lower annual volume centers, then it follows that we do not have sufficient evidence to determine whether or not those centers are high or low quality, and thus whether they should be allowed to continue a program.
Patrice?
So I actually, I hit 2. I meant to hit 3. There's nothing I can do to change that. I have it correctly on my voting sheet.
Hold on a second.
But I had similar rationale to my to number 1, that I don't think there's that it alone is sufficient.
Yeah, that's right. Okay, got it. Okay, thank you.
I have it correct. I have what I wanted on the yellow sheet, if that matters. But I voted 2 in the system.
I have good news and bad news. The good news is it doesn't matter. The bad news is it's because your vote doesn't count.
But you still do say your vote.
Okay.
Yes.
Thank you.
Question 5. How confident are you that there is sufficient evidence that a certain threshold of PCI procedural volumes must be required for hospitals with TAVR experience to maintain their TAVR programs? Is there something wrong?
One more person.
Oh. Has everyone voted? Is there anyone who hasn't voted? There we go. Thank you.
1 second. It's 9.
The meme doesn't come up to it yet, everybody. Everyone's vote. Patrice, go ahead, please.
Yes, again, I voted 2. I don't think there's sufficient evidence to maintain the PCI volume.
Thanks. Mark?
1 for the same reasons as before.
Sultan?
4, same rationales, question 2.
Dan?
4, same reasons as before.
Sandy? Yes. The first 2 votes don't count on the tabular. I tried to explain that at the beginning. So anyway, they're not included in the averages, but people still get to vote. The votes are still recorded, and then CMS deals with them. Thank you.
3, based on there's not a lot of data, but then expert opinion.
3, because again, I want to make sure that programs that started have the ability to maintain the program.
3, reflective of the last question of this, and also a little bit with somewhat more confidence with the TAVR program already in place, that those that are actually the TAVR operators would have the proficiency to be able to perform PCI, supposedly.
Right. Anita?
2.
Greg?
4.
Mike?
5.
Delicious?
5th verse, same as the first, 2.
2. Okay. Question number 6. How confident are you that the benefits of meeting procedural, that is SAVR, TAVR, and PCI volume requirements to maintain a TAVR program outweigh the harms of limiting access to TAVR to only hospitals that meet volume requirements? Great. 3.44, Aloysius?
I voted 3 on this one. It's a changing landscape. The technology and skill sets for TAVR are going to continue to improve. So I think it would limit access by imposing volume requirements for the other procedures.
Michael?
4.
Greg?
4.
Anita?
2.
Naftali?
Mine says your answer, no response received, although I voted. So I'm not sure. Was it calculated?
Yes.
Okay, so 4, and I would hope that there would be public reporting attached to any consideration of liberalization. So I just want to throw that out there, if that's under consideration, just to publicly report the actual volumes data.
Smadar?
I voted 5 again, knowing that there are other metrics that we should look into, but at the same token, without talking about this specific volume, there should be some volume requirements.
I voted 1 because I just don't like putting them all together like this.
Dan?
5, same rationale as with the program starting up.
Zoltan?
Same thing, 5, same rationale.
1, same rationale.
2, similar rationale.
Question number 7. To begin performing TAVR, now we're talking about operator requirements. To begin performing TAVR, how confident are you that there is sufficient evidence that a certain threshold of SAVR and TAVR procedural volumes must be required for the principal cardiovascular surgeon on a TAVR heart team?
Can I ask a point of information?
Yes. Yes.
So this suggests that the surgeon to start the program will have to have done both SAVRs and TAVRs, right? In other words, if we felt that it was just SAVRs, I mean, I know the question can't be changed, but how would you address that if that was the opinion?
That's how I would interpret the question as well.
So it has to be both SAVR and TAVR? Or if you feel that there should be SAVR volumes, but not necessarily TAVR volumes?
Okay, all right, so this gets into what I said. We can't change a question, but we should all vote on the same question. And we can ask for CMS guidance on this, but we may not get it. I think we can decide whether or not we are voting for the sum of SAVR and TAVR, but maybe not necessarily both for any particular surgeon, or alternatively, both SAVR and TAVR within surgeon. I guess the question of the panel is which one is more helpful to the agency to answer? Because I agree it's ambiguous.
Can you state the first option again?
Sorry. So this question could be interpreted as having a threshold of both SAVR and TAVR within a particular surgeon to qualify, or it could be interpreted as somehow the sum of their SAVR and TAVR experience, even if they have 0 of one of them. Those are different questions. I would prefer we choose which one we answer. I don't feel like I have the clinical expertise to make that choice, but is it... Go ahead.
Yeah, the fact, it states principal cardiovascular surgeon, so I assume that to mean the surgeon who will be involved in the TAVR procedure.
Right, so is there sufficient evidence, a certain threshold of SAVR and TAVR procedural volume, meaning, so you would say that we should interpret that as both a SAVR and TAVR experience within that surgeon?
Yes.
Okay, I'm fine with that. Is there any disagreement?
Yeah, I mean, I think if the surgeon has done 300 SAVRs and no TAVRs, that should not preclude, as long as there's an experience.
That's an interpretation question, right? So, but are you comfortable voting on the question whether or not CMS should be requiring both within the surgeon?
Well, again, I don't know if requiring both means that they will have to have a threshold of TAVR experience.
Hold on. Okay. All right. Clarification. The intent is, as Zoltan's question suggested, is either or. So I guess experience around the aortic valve. All right. Given that clarification, do people feel like they can answer question 7? Okay, go ahead. Yes, please.
All right, I voted 3 on this.
Oh, no, we haven't finished voting. Did we vote?
We're on number 7, right?
Number 7.
I have voted.
You voted?
Yes, for Dr.
Oh, good, all right. But did everyone else vote? Okay, there, all right.
I haven't. Go back.
You haven't voted?
No, it clicked away too fast.
Can we refresh it?
Can you refresh it? Can you start over?
We're on number 7. We want to go back to 7.
Can you clear it and go back to number 7?
Why did the wording change between these two?
Go back to this.
Okay, while we figure this out, please record your vote on paper for question 7, and I'm going to poll everyone, and maybe in the middle of this we'll figure this out, and otherwise we can do it the old-fashioned way. Has anyone not yet voted on number 7?
I haven't.
You have not yet voted? No, not on your phone, on the sheet. Can you just record your vote, please? Okay. I'm going to poll you based on the sheet, and then we'll figure out what happens here. Patrice?
I voted for.
2.
I voted 5 based on the evidence in the surgical literature.
Dan?
5.
Sandra?
4.
Smadar?
5.
5.
Anita?
3.
Tamara?
Well, not for Tamara.
No, I know, sorry.
4.
5.
3.
So the question came up on our computers, and
Why don't we try to revote on that one? We just tried to, so if we can, what you just said, please revote.
Yes, and to clarify, Tamara's reading Greg Deemer's vote. She's not voting.
not voting
I
on
was
behalf
being
of CMS.
snide because it's the end of the day, but CMS doesn't get a vote.
That's 9. All right, we good? Okay, we're good.
Okay, good. Yeah, that's what I had to. Okay. Question 8. To begin performing TAVR, how confident are you that there is sufficient evidence that a certain threshold of structural heart disease procedural volumes must be required for the principal interventional cardiologist on a TAVR heart team?
we still have polling closed.
Yeah, we're working on it.
Okay, could you please record your votes on the paper?
Can I ask a clarifying question?
Absolutely.
So it's just procedural, structural heart disease procedural volumes, no specific procedures?
That's correct.
Okay.
That's how I read it as well, at least.
Okay.